Kia ora. My name is Craig Johnson, and the plan today is to look at the physiological effects of hemorrhage. My background is in veterinary anaesthesia, and I've spent a lot of my time dealing with animals that are bleeding for one reason or another. And so what I want to do today is to go through some of the physiology that you've already covered and talk about how that physiology is important when we're dealing with an animal that is losing blood. As I said at the outset, we're going to use our current physiological understanding to explore the pathophysiology of blood loss. And when I do this with a group of students, I ask a lot of questions, and I don't actually give very much new information. I focus on what is already known. And I guess what I'm trying to say here is that in terms of physiology, the learning outcomes are that you should be revising the physiology you already have and maybe making links between different aspects of physiology that were not very secure. I don't think that there's any new physiology that you need to learn in order to understand what we're going to do. I will be asking some questions as we go through, and when I do ask those questions, I think it's really important that you take some time to think about the answers to those questions and whether or not you know those answers and how well you understand the material. I won't be pausing because this is a recorded PowerPoint presentation and there's a pause button, so you can stop anytime you want to, but please make sure that you understand why we're dealing with the questions that we're dealing with in the way that we're dealing with them. There will be some clinical significance that I will put in, and some of that may be material that you haven't met before. That is largely for interest and so that you can see how the physiology that we're dealing with integrates with some of the clinical subjects that you'll be dealing with later on. It's at a very introductory level, and don't worry so much if you don't understand that material, because you'll be covering it again when you get to the clinical years. This is really about understanding the underlying physiology and working out how we can use that to decide how the body responds to hemorrhage and what we should do about it as clinicians. The cunning plan then is to revise the underlying physiology that will allow us to understand an experiment that I'm going to present to you that we did a few years ago. We're then going to interpret the experimental data. We're going to discuss the clinical significance of the data that we've recorded, and then to close the loop, we'll review that pesky physiology at the end. The experimental overview then, we are going to take one sheep, we're going to anaesthetise it, we're going to arrange to measure its blood pressure, and then on 3 separate occasions we are going to remove 10% of its blood volume, and we're going to replace that with a fluid of some kind. The first time we go through that cycle, we'll use normal saline as the replacement fluid. The second time we go through that cycle, we're going to use a dextrose solution, and the third time we're going to use a dextran solution. As I said at the outset, there will be questions, and here are the questions that we need to address about the physiological background. Let's look at the first 3 together and see how we get on. So, if we represent the total body fluid as a rectangle, you'll recall that it's divided such that approximately 1/3 is extracellular and 2/3 are intracellular, and that the extracellular is subdivided such that about 1/3 of it is plasma, the fluid which is in the blood vessels, and approximately 2/3 is interstitial. And if we check our maths using our original estimate of blood volume being about 100 mils per kilo, you can see that the 1/3, the plasma fluid, of the 1/3 extracellular fluid is about 1/9 of total fluid, and that is approximately equal to 10%, which is around about 100 mils per kilo. I'll just get rid of my working there, and we can go on and look at those compartments. It's worth noting that there is no difference between a water molecule in the plasma space or the interstitial space or the intracellular space. What keeps the fluid in those spaces are the solutes which exist in those spaces, which hold the water molecules in those spaces by osmotic pressure. And so in order to understand those spaces, we need to understand the structures which bound those spaces. And in the case of the extracellular intracellular space, the structure which bounds here is the plasma or cell membrane. It is impermeable to sodium ions, and so the sodium ions define the extracellular fluid space, and the intracellular fluid space is defined by potassium ions. In the case of the plasma space versus the interstitial space, then the structure which bounds here is the capillary membrane. It is impermeable to the passage of large molecules, and the large molecules which exist in the plasma are plasma proteins. They cannot get from the plasma into the interstitial space, and so the plasma proteins contribute to the oncotic pressure in the plasma space, and so help to define that plasma space and separate it from the interstitial space. Let's go on now to talk about the effects of blood loss. This is a diagram that I've adapted from a physiology text, and you can find diagrams like this in many different physiology texts. But if you look at it, you'll see that at the top I'm considering the effects of hemorrhage, and down as we go through it there are various things that are happening, and there is a colour code to this diagram. Anything that is reduced is in blue, anything that is increased is in red, and anything in green is a group of effects that will be unpacked later on. And so that you can see that hemorrhage causes a reduction in blood volume. That has direct effects which lead to a reduction in arterial pressure, and also effects on the renal system and autotransfusion, and via reduction in arterial pressure on the baroreceptor reflexes, which leads to an increase in circulating erythrocytes, arterial blood pressure and plasma volume. Let's go on then to look at the direct effects, and if I unpack those, you can see that hemorrhage leads to a reduction in blood volume. That triggers the renin-angiotensin vasopressin system and leads into the renal effects that we will look at shortly, and also triggers thirst, which leads through drinking to autotransfusion, and we'll look at the autotransfusion effects shortly. But directly, blood volume causes a reduction in venous return, which causes a reduction in stroke volume and a reduction in cardiac output, a reduction in arterial pressure, and then through decreased capillary blood pressure, autotransfusion, and through decreased firing of baroreceptors, stimulation of the baroreceptor reflexes. If we go on then to look at the baroreceptor reflexes, this is what we see. This is the busiest slide of the selection, but if you look at it in columns, you'll see that we have got parasympathetic and sympathetic stimulation of the heart, sympathetic stimulation of the veins, sympathetic stimulation of the arterioles, and sympathetic stimulation of the spleen. And all those lead to a various number of outcomes, which are increased circulating erythrocytes through splenic contraction, renal effects through arterial vasoconstriction, and increase in arterial pressure through increase in cardiac output and increase in total peripheral resistance. And now would be a really good time to look at the relationship between blood pressure, total peripheral resistance, and cardiac output. If you don't fully understand that, it's a fairly straightforward application of Ohm's law. Going on to look at autotransfusion, you can see that autotransfusion leads to a reduction in capillary blood pressure, and renal reabsorption is increased and renal filtration is decreased. All of that leads to a fluid shift from the interstitium to the plasma because of the oncotic pressure of the plasma, which is increased, and that's also contributed to by hepatic protein synthesis, which increases the oncotic pressure. That increased pressure in the plasma space increases plasma volume, and also you can see the reduction in blood volume and thirst increases plasma volume, but also that increase in plasma volume through Starling's law leads to the baroreceptor reflexes. And again, if you don't fully understand Starling's law, now would be a really good time to stop and have a look at that. Finally, we've got the renal effects, and although these tend to take place more slowly, they are actually the most powerful of the effects and are the ones that can lead to a complete reversal of a hypotension. Starting in the middle here then, renal blood flow going up leads to an increase in erythropoietin synthesis and an increase in circulating red cells, and going down, reduced renal blood flow leads to reduced renal output, which increases plasma volume. And you can see that I've put the direct effects and also the baroreceptor reflexes back onto this graph. So looking at the whole thing again, you can see how these physiological effects relate to each other and how the response to hemorrhage leads to an increase in circulating erythrocytes, an increase in arterial blood pressure, and an increase in plasma volume. So now we need to consider the differences between the three different fluid replacers that we're going to use. If you remember, we considered the body fluid to be divided into two compartments by the plasma membrane, the plasma or cell membrane, and the extracellular fluid to be divided into two compartments by the capillary membrane. The first fluid that we're going to look at is normal saline. And when we look at this, we need to think about the sodium ion. So we put normal saline as a replacer into the plasma space. Can it diffuse across the capillary membrane into the interstitial space? Yes, it can. Can it diffuse across the plasma membrane into the intercellular space? No, it can't, because the plasma membrane is impermeable to sodium ions. So that means that when we replace blood loss with sodium chloride, we are replacing loss from the plasma space into both the plasma space and the interstitial space. And because the ratios here are 1/3 to 2/3, that means that for every 100 mils of blood loss that we replace with sodium chloride, we need to use 300 mils of sodium chloride to replace that, because 2/3 of the volume goes across into the interstitial space. For the second fluid, we're going to look at using dextrose saline. As soon as dextrose comes into contact with a cell membrane, it's taken up through the action of insulin, and so it disappears from the extracellular space. And that means that giving dextrose is just a cheat's way of giving water. If we give pure water intravenously, we upset the osmotic balance within the blood, and that causes fluid to rush into the red cells, causes them to expand and eventually lyse, and that's a bad thing. So we balance the osmotic pressure of the blood with dextrose on the understanding that as soon as it gets there, it's going to be taken up into the cells and disappears. And we're left with water. Can water cross the capillary membrane? Yes, it can. And can it cross the plasma membrane? Yes, it can. And you'll remember that when we did the sums comparing the plasma space to the whole of the body space, we came up with 1/9 here and 8/9 here. And so that means that whenever we give fluid into, or water into the plasma space, only 1/9 of it stays in the plasma space and the rest of it diffuses through the rest of the body. And that means that for every 100 mils of blood loss that we replace with a dextrose solution, we need to provide 900 mils of dextrose solution to adequately replace that loss in the plasma space. The last fluid we're going to look at is a dextran. Dextrans are polysaccharides, and the important thing about them in terms of today is that they have a large molecular weight. And the dextran that we're going to use is dextran 70, which has a molecular weight of 70,000 Daltons. About the same as a medium-sized to smallish protein. When we give that dextran into the plasma space, can it cross the capillary membrane? And the answer is no, it can't. And so all of the fluid that we give with the dextran is trapped in the plasma space, and that means that if we replace 100 mils of blood loss with a dextran, then we need to give 100 mils of dextran to do that. And so that you can see that these three potential fluids that we might use, sodium chloride, dextrose and dextran, have very different effects when they're given into the plasma space because of the limitations of the compartments which their fluid can diffuse into. Time now to take a break from the physiology and have a look at the experimental procedure. You've seen this overview before, and what I'm going to do now is show you a series of video clips which demonstrate how we actually collected the data from the experimental setup, and once we've done that, we'll have a look at the resultant data and go through it and talk about some of the changes that we see. If you're going to anaesthetise a sheep, the first thing you need to do is to do a clinical examination. And so here you see a sheep being restrained, and here I'm coming up and giving it a clinical exam. Because it's a sheep, I'm focusing on its nose and its mucous membranes to make sure that its mouth is moist and it's not too dehydrated, to make sure that its nose isn't snotty, because sheep are very good at Pasteurella, to make sure its colour's good. And now you can see I'm listening to its heart and feeling its pulse with my left hand at the same time, so that I can make sure that the heartbeats are regular and there's a pulse for every heartbeat. And now I'm listening to the lungs, because again, sheep are good at respiratory disease, and we don't want to anaesthetise a sheep thinking it's healthy, only to find out that its lungs are full of respiratory disease. That will be a bad thing. Listening to the chest over all 4 lung fields and making sure that I can't hear any undue crackles or wheezes. We're going to anaesthetise this sheep by intravenous injection, and the drugs we're going to use don't matter, but what is important is that we have a route into the vascular space so that we can inject them, and so we're going to cannulate the jugular vein. Here I am clipping the wool away from the jugular vein so that we can see what's going on, and in general it's a good idea to clip a big area of the skin over the vein so that you can see what's going on and see the vein under the skin. I'm now moving the wool away and I'm pushing my thumb into the jugular groove to raise the vein to fill it with blood, and you can see, if you look now, that the jugular vein is under the skin in the area marked. The next thing that I'm going to do is to inject a small volume of local anaesthetic into the skin directly over the vein. That's going to create a wheal or a bleb, and that means that for everything else that I do, I'll be working in that wheal and the sheep won't feel what I'm doing because of the local anaesthetic. This is an 18 gauge intravenous cannula that I'm placing into the vessel. You'll see in a moment that I will get blood in the flash chamber to indicate that the cannula is in the vessel, and once I do that, I'll be advancing the cannula up over the stylet until it sits in the vessel. Then I'm going to be attaching a 3-way tap to the end of the cannula and flushing that with heparinized saline, which will make sure that the blood in the cannula doesn't coagulate. For the rest of this video, you'll see me suturing the cannula into the wheel. Different people choose to attach cannulae in different ways. Some people use super glue. I'm a fan of suturing, and I do recall that I sutured when I was doing my residency in anaesthesia, and then I moved to a different clinic as a faculty anaesthetist where super glue was used, and on the first day I thought to myself, I can be flexible and I can start to use super glue. And the first morning I was there, I superglued my finger to the jugular groove of a horse that I was supposed to be anaesthetising, and so that was a bit embarrassing, and since then I've just kept on with suturing. Now we're going to induce anaesthesia. The sheep is restrained in this sitting position with its head up, and once ruminants are anaesthetised, they lose the ability to control their laryngeal reflexes, and they very often regurgitate. That's what ruminants do. And so you'll notice that when we anaesthetise this sheep, we're going to keep its head in an elevated position right until we not only get the airway intubated with an endotracheal tube, but until we get the cuff inflated so that we have what we call a secure airway. That was the anaesthetic drug injected, and I flushed the catheter with hep saline, and you can see now that the sheep is relaxing and is becoming anaesthetised. Neil now is going to hold the mouth open for me and bring the sheep into a sitting up position, but with its head still elevated. I'm going to take hold of the sheep's tongue, and I'm going to put a laryngoscope down so that I can visualise the rhemoglottidis, the entrance to the airway. I'm popping the endotracheal tube down into the airway, but the airway is not yet secure, and we need to inflate the cuff to create a seal around that endotracheal tube before we can safely put the animal's head down. Now we're going to cannulate the femoral artery. There are a number of ways of measuring blood pressure, and they have their advantages and disadvantages, but we're going to put a cannula into the femoral artery. It's very similar to putting a cannula into a vein, except instead of doing it by visualization of the vessel, I'm doing it by palpation. And so here I'm feeling for the femoral pulse, and when I'm happy that I've got the vessel under my fingers, I'm going to advance the cannula towards the vessel so that I can feel both the cannula and the vessel. And the vessel, because it's an artery and is rubbery and thick-walled, is going to try and wriggle out of the way, so sometimes I need to come back, reposition a little bit and go forwards. Then I get the flashback, and it's time to advance the cannula into the vessel. And for the rest of this clip, you'll see me putting the usual three-way tap with the hep saline on, flushing the vessel, and then suturing the vessel into place. We're going to take a continuous recording of the pressure from this arterial line all the way through the experiment, and the key thing that we will be looking at is the change in blood pressure that is instituted by removing the blood from the sheep and infusing the replacement fluids after we do that each time. There are lots of ways of getting blood out of a sheep, but one of the fastest is through a cannula in the carotid artery. And so the next clip shows the dissection of the ventral neck to get into the carotid artery and the placement of a glass cannula. You'll notice that this looks a bit like a surgical procedure, but actually it's very different. There are a number of key differences that we are seeing here which you wouldn't see in a surgical procedure. One is the lack of sterility. Obviously, if you're doing a surgical procedure, the animal would be intended to recover, and so we would need to keep post-operative infection to a minimum. In this case, there's no need for sterility, and so we are not using drapes, gloves, gowns, sterile instruments, and so on. The other is that if you see a surgeon make a surgical approach to a carotid artery, the hole will be much smaller. And again, that's because the animal has to recover from the surgery and we want to do as little tissue damage as possible. Here we don't have the need for that, and so we're making a relatively large hole so that we can better identify the tissues and more easily and quickly isolate the carotid artery and cannulate it. Professor Lapwood, who's the surgeon here, is now identifying the carotid artery in the carotid groove, and it would be sensible for you at this stage to revise the structures that run with the carotid artery through its vascular plane in the neck, and think about what the effects of accidentally hitting one of those with the scissors or cutting it might be. Keith's identified the carotid artery now, and so he's putting the forceps down between it and the other structures, and there you can see the vascular sheath and the carotid artery isolated. In order to have control of the cannula, now some ligatures are going onto the carotid artery, and the first ligature is going to be tied tight around the artery as an anchor for the cannula when the cannula is put in place. Now you can see that I'm placing a second loop of suture material around, and now with those two loops we've got really good control of the vessel. Keith's tying that first loop off so that that will be a support for the cannula when the cannula is eventually placed. And now he'll put a bulldog clamp onto the carotid artery to prevent any blood from flowing while the cannula is being placed. And then with a fine pair of iris scissors, he's going to make an incision into the side wall of the carotid artery. And once he's into the lumen, he's going to get a glass cannula and feed that cannula down into the lumen of the carotid artery. There we go. Once that's placed, we're going to use the proximal ligature to tie it in place, and when it's all tied up, take the bulldog cannula off, and you can see how quickly the blood flows out of the carotid artery into the cannula. You'll recall that we said we were going to take 300 mils of blood from the sheep on 3 separate occasions, and this is an example of that removal of the 300 mils of blood, the 10% of the sheep's blood volume, to show you how quickly that can occur when we open up the cannula in the carotid artery and allow that blood to pour out. Here we're collecting it into a measuring cylinder so that we know we are allowing the right volume of blood to bleed out from the circulation. %, of the blood volume in about 30 seconds. Inevitably it takes longer than that to replace that volume of fluid, but this is a section of video just to show us replacing the fluid, and as you'll recall, the first time we do that we're going to do it with normal saline, the second time with a dextrose solution, and on the final occasion we're going to do it with dextran. But on each occasion we are replacing the volume of fluid loss. We're not replacing the estimated required volume of fluid to be a full replacement in the plasma space. And again, if you're not sure about the difference between those two concepts, now would be a good time to have a think about that and maybe review the earlier parts of the video where I was talking about different fluids filling up different body compartments when they're given intravenously. So this is a data trace of the entire experiment, and we have the ECG across the top in red and blood pressure recorded directly from the catheter that we placed into the femoral artery in blue, and you can see that down the bottom we have various notes of times of different things, and so this is the start and finish of the first bleed, this is the start and finish of the first infusion, and so on and so forth through the experiment. What we're going to do now is we're going to go through the entire experiment and just talk about what the effects were of taking 10% of the blood volume and replacing it with the different fluids. One of the things that I can do when we're looking at it like this is I can stretch out and squeeze down the timeline, and so for example if I progressively stretch and stretch and stretch the timeline, you can see that we can get a trace that looks very different, and I can move over the course of the experiment right back to the start. And I want to start here because at this point we have a normal looking ECG, and you can identify P waves, QRS complexes and T waves going through here. And if you look at the blood pressure trace, you should be able to see the systolic blood pressure here at the peak and the diastolic blood pressure. And there are two other things that I want you to look at on the trace. One of them is the rate of rise of the blood pressure in the early systolic period, and the other is a notch here called the dicrotic notch. Those are useful because although they're not the best indicators of the two things that they're indicators of, they are very good indicators that you will have access to in a clinical setting. And so the rate of rise of the blood pressure trace in the early systolic period here is a really good indicator of cardiac contractility. And the dicrotic notch here, the notch in the middle of the blood pressure trace, is a really good indicator of the degree of fill of the cardiovascular system. And so when we take blood out of the system, not only will we see the blood pressure change, but we will see changes to the shape of this waveform. Let's go back now and look on a much larger scale. There we go. And here we have the start and finish of bleed 1. And you can see that the arterial blood pressure starts at around about 150 millimeters of mercury, and that's over 115, so 150 systolic over 115 diastolic, and that falls over the period of the bleed down to around about 115 over about 75. And so you can see that that's quite a change. We'll discuss that change further in a minute, but before we do, I just want to have a look at the shape of the waveform at the bottom of that peak. It's just back here. There it is. And if you look at the shape of the waveform now, you can see that the dichrotic notch has completely disappeared from the waveform, and we've just got a single peak for every QRS complex or every heartbeat. And that's because we've made the animal hypovolemic. And so that gives you an idea of the way in which we can use the shape of the blood pressure trace as an indicator of the degree of fill of the vascular system. The question I want you to consider now is this hypotension a significant hypotension? Is it physiologically significant? And by the same logic, is it clinically significant? Is it a hypotension that we need to do something about? And if so, why? How does it affect the animal? And in order to decide that, we need to think about what the blood pressure does and how this change in blood pressure might change the circumstances for the animal. So, we've already answered the first question, but to revise that, you'll remember that the shape of the pressure waveform has two interesting parts. One is the early systolic part, and here the rate of rise is a really good indication of cardiac contractility. The steeper the rise, the more contractile the heart. The less steep the rise, the less contractile the heart. And secondly, the dichrotic notch is a really good indicator of the fluid fill or degree of volemia of the cardiovascular tree, and when that notch disappears, that's a really good indication that the animal is hypovolemic. Looking at what we mean by a clinically significant hypotension, we need to think about what the blood pressure is for, what it's giving us an indication of, and what is important in the cardiovascular system. The cardiovascular system is all about delivering oxygen and substrate to the tissues and about removing waste products, and among them carbon dioxide. And so it's all about perfusion. If we look at the link between blood pressure and perfusion, we can draw a graph, which you'll have seen before, which has perfusion on this axis and arterial blood pressure on this axis. And I'm hoping that you will all be familiar with the shape of this graph, and you'll recall that it increases and then has a plateau and then increases again. This period or area where there is a plateau is indicating that for a range of blood pressures, the perfusion remains constant. This is the part of the blood pressure perfusion curve where perfusion is not pressure dependent. But in this part of the curve and this part of the curve, perfusion is pressure dependent because a change in perfusion
or rather a change in blood pressure, alters perfusion. In the middle here, a change in blood pressure does not alter perfusion. The limits of this area are quite broad, but generally speaking, the lower limit is around about 60 millimetres of mercury, and the upper limit is around about 140 millimetres of mercury. A reduction in blood pressure or hypertension then that reduces mean blood pressure but doesn't reduce it to less than 60 millimetres of mercury does not move blood pressure into this pressure dependent area of perfusion, and so wouldn't be expected to change organ perfusion. When the mean blood pressure falls below 60 millimetres of mercury, then we move into this perfusion dependent area or pressure dependent area where perfusion is dependent on blood pressure. And now changes in blood pressure will change organ perfusion, and so we have a clinically significant hypotension. The difference between not clinically significant and clinically significant is whether or not the change in blood pressure that we see alters the perfusion of the tissues.
Going back to the data, you can see that there is a reduction in blood pressure over the course of the first bleed, a hypotension, but that the mean blood pressure doesn't drop below 60 millimeters of mercury, and so this is not a clinically significant hypotension at this stage. Note that after the cessation of the bleed, even though no treatment has been implemented, the blood pressure does increase over the period of the next 2 or 3 minutes. And that increase is due to the physiological mechanisms that we discussed earlier, which address a sudden blood loss. So we're talking here about sympathetic nervous system stimulation, we're talking about autotransfusion, and the renal effects, which have the capacity to completely restore blood pressure to normal, take 2 or 3 days to do that. And so you can see that this immediate increase peters out and the blood pressure stabilizes at a lower level than it was initially. If we move on to look at the period of the first infusion, and I will concertina this up a little so that we can see it more easily, you can see that over the course of the infusion the blood pressure increases, and it increases to a level that is more or less equivalent to where it was at the start of the experiment. And then after the end of the first infusion, which you'll remember was normal saline, there is a reduction in blood pressure before stabilization. And again, that reduction is because over the first few minutes after the end of the infusion, some of that water escapes from the plasma space into the interstitial space because the capillary membrane is not impermeable to sodium ions. Going on to look at the second bleed and infusion, you can see a very similar profile, although the effects are more severe than the first bleed. We still don't have a clinically significant hypotension, although it is getting closer and closer to that. And again, you can see that this time the physiological mechanisms increase the blood pressure after the end of the bleed, but that they are unable to stabilize the blood pressure, and so the blood pressure continues to drop over the next period until the fluid is started and the infusion increases blood pressure again to a level that is more or less where it was at the start of the experiment, although not quite this time. And then over the period after the end of that, you'll see that there is a slight and this time ongoing reduction in blood pressure. And again, this second infusion was dextrose saline, and so the dextrose solution gives effectively free water, and the free water equilibrates not only through the extracellular fluid but through the whole of the body fluid. It's interesting that the effects of this second bleed are more severe than the first bleed, and that really emphasizes that taking a volume of blood out of an animal and replacing it with a volume of fluid that is not blood addresses some of the issues of the blood loss but not others. Specifically, we are partially addressing the fluid loss issues, the volume issues. We're not addressing the protein loss issues, and those are beginning to become significant at the point of the end of the second bleed, where we have a cumulative 20% blood volume reduction or loss. And as we get further down the picture, we'll start to see that the animal is running out of oxygen delivering capacity as well. So if you look at the start of bleed 3, you'll see that now there is a precipitous drop in blood pressure, and we're beginning to get towards a clinically significant hypotension, even though this time we've only removed the same amount of volume as on the first two occasions, and you'll remember we replaced that volume, albeit with different fluids. You'll see that this time after the bleed there's almost no recovery, and then the blood pressure continues to get worse over time. And this indicates that the animal has reached the end of its physiological reserve, the end of its physiological capacity to compensate for that ongoing blood loss. Infusion 3 increases blood pressure, not this time to the same level as we were at the start of the experiment, but only to a level which is moderately, although not clinically significantly, hypotensive. Note that after the end of this third infusion, there is a slight decrease in blood pressure, but blood pressure remains fairly stable. There's not the gradual decrease in blood pressure over the first few minutes that we saw with the other solutions. And remember that this time this infusion was a dextran solution. It took longer to give the infusion than the other infusions because dextrans tend to be more viscous than crystalloid solutions, but the fluid, once given into the plasma space, is bound in the plasma space by the capillary membrane, and so you don't get that autotransfusion out into the interstitial and or the intercellular space. That brings us to an end of the consideration of the data, and I hope that's given you an appreciation of the role of the cardiovascular system in compensating for blood loss, and also the beginnings of an understanding of the options that we have to replace that blood loss and the advantages and disadvantages of some of the fluids that we can choose. This is a 2-hour practical class, and it's taken me something under an hour to go through it without asking questions. You should take home from that it would be a good idea to spend some time just going over the underlying physiology and making sure that you understand what's going on, so that if you are asked questions in the future, you can begin to answer them in a physiological sense, and also so that as you move on into the clinical parts of your studies, you can begin to understand the clinical effects that pathology and your treatment is having on animals in a physiological sense, and so enhance your ability to understand disease processes and the process of healing. Thanks for your time. See you later.